We're very lucky today to have Dr. Jim Crismale for his grand rounds on the utilization of hepatitis C positive organs in transplantation. Dr. Crismale received his medical degree from UMDNJ Robert Wood Johnson and has been with us here at Mount Sinai since, where he completed his residency in internal medicine, served as a chief resident, received his fellowship training in gastroenterology and advanced fellowship in transplant hepatology. Dr. Crismale currently practices as a transplant hepatologist within the Recanati Miller Transplantation Institute here at Mount Sinai, where he serves as an assistant professor. His research interests are in improvement of outcomes before and after liver transplantation, with a particular interest in the impact of new treatments of hepatitis C in the context of liver transplantation. As a clinician and educator, Dr. Crismale is truly exemplary. His passion for hepatology and medical education make him a regular favorite amongst our house staff and the medical students. Please join me in giving a warm welcome to Dr. Jim Crismale.
Good morning, everybody. Thanks, Alex. Thanks for inviting me to speak today on a topic I find really exciting, which is the transplantation of Hep C positive organs into Hep C negative recipients. This is a topic that we couldn't be discussing 5 or 6 years ago, and this is all possible due to the new treatments for hepatitis C, the direct-acting antiviral agents. So, a couple of objectives for this morning. Number one, we're going to briefly describe the extent of the problem, which is the organ shortage in the United States, using the liver transplant list as a framework. We're going to discuss some of the changing epidemiology of Hep C in the US as it relates to our donor pool, and then we're going to discuss the prior experience with transplantation with hepatitis C positive organs in Hep C positive recipients. And then finally, we'll review some of the current data, albeit limited, assessing the safety and efficacy of transplantation of organs from Hep C positive donors into Hep C negative recipients. So I'm going to start with a case. Back when I was an intern and a resident, one of the house staff always prefaced grand rounds by doing a case presentation, and I never actually got to do that, so I figured I'd do it today. So this is actually a case that was published in Liver Transplantation by one of my colleagues, Dr. Behnam Saberi, last year. So this is a 57-year-old woman with Child-Pugh Hep C cirrhosis. She had previously been cured of her Hep C with cimeprevir and sofosbuvir, and she was listed for liver transplant with a MELD of 12. So she was low on the list, but she was sicker than her MELD and had multiple complications of portal hypertension. She had been waitlisted for 3 years with no transplant in sight, and she had no living donors available, so she couldn't get transplanted outside of being on the waiting list. So in order to try to expedite her getting a transplant, she agreed to accept a liver from a viremic donor with the knowledge that she would potentially require retreatment for Hep C. So her donor was an 18-year-old man who died of a heroin overdose. His biopsy before procurement showed moderate portal inflammation, mild interface hepatitis, and minimal fibrosis. She underwent a successful deceased donor liver transplant, and 3 days after transplant had detectable Hep C viremia. So in response to that, her providers ordered her for ledipasvir sofosbuvir, also known as Harvoni, and they were able to obtain authorization from insurance and start treatment by post-op day 25. After 8 weeks on treatment, the patient had an undetectable Hep C RNA, and then after completing treatment, she had a sustained virologic response 12 weeks after completing treatment. 2 years later, she had excellent graft function with no detectable Hep C RNA. So this is actually one of the first case reports of the successful intentional transplantation of a donor liver from a patient with viremia into an uninfected recipient. And this is actually a really illustrative case because it reflects both the real-world practice of needing to wait for insurance authorization before we actually start treatment in these patients, and it highlights the strategy of us trying to expedite transplant for a patient who's disadvantaged on the waiting list by offering them transplantation with a viremic organ. So first, we'll take a step back and talk a little bit about the mismatch between supply and demand on the organ transplant lists in the US, which will give us a little bit of a scope of the problem. So currently, there are about 13,500 patients waiting for liver transplant nationally, and that number's only increased over time. So back in 2015, the number was around 10,600, and now 13,500. And a lot of that's driven by a couple different factors. So number one, we have an older population, and we're listing more elderly patients for transplantation. So there's an increasing number of patients on the waiting list who are over the age of 65. We also have the twin epidemics of alcohol-related liver disease, which is becoming especially prominent in young patients, as well as non-alcoholic fatty liver disease. And listing for liver cancer, hepatocellular carcinoma, has also increased over time as we accept more patients with extended criteria outside traditional Milan criteria for liver transplant. So with that big of a list, we also have a relatively high waitlist mortality on the liver transplant list. So these are data taken from UNOS. So back in 2012, if a patient was listed, 3 years after that, by 2015, around 20% of those patients either died or had to be removed from the liver transplant waiting list for being too sick for transplant. So back in 2012, there were around 10,000 new listings for transplants. That works out to about 2,500 patients. So that's a lot of folks who are dying or being delisted for transplant because they're too sick. And the patients who are dying on the transplant list are our really sick patients. So these are patients with a MELD score of 35 or higher. Remember, we order patients on the waiting list depending on their MELD score, and MELD is predictive of 90-day mortality. So if a patient's MELD is 35 or higher, their 90-day mortality is between 50 and 75%. And depending on what part of the country you live in, including ours, your MELD score needs to be really high sometimes before you get an organ offer. So if you're a blood type O or an A, your MELD score in New York, currently anyway, needs to be in sort of the mid-30s before you get an organ offer. So ideally, we'd like to transplant patients before they get into this situation where they have a very high mortality on the waiting list. But we're hampered by the fact that we just don't have enough organs. So these are data taken from an inpatient survey study where they looked at the number of inpatient deaths and tried to estimate from this the number of estimated potential donors. So back in 2010, there were a total of around 800,000 inpatient deaths. And from that population, when looking at folks who had died with a brain death, people who were mechanically ventilated, and people who had diagnoses codes that were compatible with being an organ donor, there were around 37,000 estimated donors. However, that year, only 7,900 donors actually were accepted for organ donation. So there's a huge gap here between estimated donors and actual donors, and if we could fill this gap, we could potentially transplant more patients and save some extra lives on the transplant list. So how are we going to do that? Number one, we have to really encourage more donation. That's the bottom line, is that more people need to sign up to be organ donors. And we need to do that excuse me, by educating the public about being an organ donor, and because there's still a stigma around being an organ donor where some people think that they may not get excellent care when they come into the hospital. So we have to do our part to educate people about that. We also try to encourage living donation, where patients can get transplanted outside of being on the waiting list, where they don't have to wait for a deceased donor. They can have a friend or family member or someone close to them donate an organ. And then we have to consider the use excuse me, of expanded criteria donors. So these are older donors, people who die after a cardiac death, those donors with steatotic grafts or fatty livers, donors who maybe have a history of cancer, and then donors who have a risk of transmitting infection to the recipient. Specifically for our talk, we'll talk about donors who have hepatitis C and the risk of transmission of that infection to recipients. So if we did maximize the utilization of hepatitis C positive livers, how much of that gap can we really bridge? Right? So back in 2014, from this same deceased donor potential study, there were an estimated 860 hep C seropositive potential donors. However, during that same year, only 139 seropositive donors were actually utilized. So when you account for the fact that some of those 860 aren't going to be acceptable potential donors because of fibrosis in the liver or other factors, that's still around 300 to 500 potential donors, which means that's 300 to 500 additional lives that could potentially be saved with maximizing utilization of these livers. When we talk about hepatitis C positive donors, it's important to keep in mind the terminology that we're using, because even in the literature, the terminology can be a little bit confusing. So we have both seropositive donors, which are donors who test positive for anti-hep C antibody, and we have NAT positive donors, which are patients who test positive for nucleic acid testing or hep C RNA. We also refer to them as viremic donors. Remember that when patients get infected with hepatitis C at the time of their exposure, there's a short eclipse period of about 5 to 7 days before they can actually have detectable viremia by nucleic acid testing. And then it takes about 2 to 6 months before they serologically convert and start producing anti-hep C antibody. So when we're talking about donors, if we talk about a seropositive donor, that's someone with anti-hep C antibody, and that can be someone with chronic infection where they have anti-hep C antibody plus RNA, or someone with a resolved infection. When we talk about a NAT positive or a viremic donor, this is someone who can be in this acute phase of infection or someone with chronic infection. And it's really important that we differentiate here because the risk of transmission from donor to recipient is very different depending on what kind of donor you're looking at. So if someone is NAT positive, they have a risk of transmitting Hep C of about 90 to 100%, probably closer to 100%. And if they're seropositive only and NAT negative, that risk is around 0 to 9%, probably closer to 0%. It's also important to keep in mind that when we look at the literature for this, UNOS only started mandating RNA screening of donors in around late 2014, early 2015. So when we look at older studies, when we talk about Hep C positive donors, what they're really referring to here are seropositive donors. So that can be patients either with resolved infection or with chronic infection. So where do these donors come from? So there's two main populations from which we can derive Hep C seropositive or viremic donors: the baby boomers and persons who inject drugs. The baby boomers, as we are all familiar with, are the population that we traditionally think of as having a very highly concentrated prevalence of hepatitis C, and this is what has driven birth cohort screening. So these are folks born between 1945 and 1965. But as a population for viremic donors, this is shrinking because many of these folks have already been treated for their Hep C, and many of these folks have already died related to their Hep C or related to extrahepatic disease from hepatitis C, like coronary artery disease or diabetes. Also, when these folks are up as potential donors, their organ viability may be lower because if they've had chronic hepatitis C for a long time, they may have significant advanced fibrosis or cirrhosis, so they may not really be viable donors. So where we're really looking to in terms of hepatitis C positive donors are this population of persons who inject drugs. Even in our own backyard, we can see this shifting of demographics. So this is a slide I borrowed from Dr. Dietrich, where we can look at the prevalence of hepatitis C in different age groups. So back in 2005, again, most of hepatitis C was concentrated in this baby boomer population. But in 2016, that curve has shifted to now sort of a bimodal distribution where you have still a good prevalence of hepatitis C in the baby boomer population, but also this peak in the younger generation, age 21 to 37. And this reflects what's going on around the country. So even though we have these highly effective direct-acting antivirals, there are still around 2.4 million patients in the US currently infected with hepatitis C, and a good proportion of those folks don't know that they're infected. Part of this is driven by an increase in Hep C incidence over the last decade, which has tripled. And we think that this is really driven a lot by the opioid epidemic and an increase in rural persons who inject drugs. So a lot of Hep C prevalence has become concentrated in areas that have been hit hardest by the opioid epidemic. So this is Appalachia, certain southern states, and then some western states as well. In one study from Kentucky, the prevalence of Hep C in a population of people who inject drugs was close to 55%. And when you compare that to the national prevalence of 2 to 3%, that's a pretty striking concentration of hepatitis C in a group of patients. And this goes hand in hand with the increase in opioid-related deaths that have occurred. So this is very widely publicized, but since 2000, there's been a 200% increase in opioid-related deaths, and this is mainly related to prescription opioids, fentanyl, and heroin. In 2014 alone, there were 47,000 drug overdose deaths in the US, and this is more than any previous year on record. And what's really tragic is that most of these deaths are occurring in young patients between the ages of 25 and 44. Again, this is geographically centered in Appalachia, where the opioid epidemic has hit the hardest, and there's significant overlap with the prevalence of hepatitis C in these groups. So this has really led to changing demographics in our donor population. So, when patients who die of opioid overdose die, occasionally they'll die of anoxic brain injury, and if they are brain dead and still have their heart beating and their organs are being perfused, they could potentially be donors. So we're seeing an increase in the proportion of donors with drug intoxication as a cause of death. So from 4.3% to 13.4% from 2010 to 2017. There's been an increase in those who are potential donors who die with injection drug use as a mechanism of death. So an increase from 1.3 to 8%. Going hand in hand with that is an increase in Hep C seropositivity in the donor population, so increasing from 4.2 to 7.3%, and an increase in viremia in donors from 3.9 to 4.9%. Remember, because a lot of these patients are dying young, this has led to a decrease in the median age of our hepatitis C positive donors. So back in 2010, the median age of a hep C positive donor was 48. And in 2016, the median age of a hep C positive donor was 35. So we have more hepatitis C positive donors, and they're dying younger, which, when we look at it from a donor perspective, in some ways is good, because this means that these organs could potentially be more viable, and we can utilize these organs for transplantation. So we've been doing transplant with hepatitis C positive organs for quite some time, but we've been doing them mainly in hepatitis C positive recipients. So I want to share some of those data with you, because that'll help us inform our discussion about transplantation from hepatitis C positive to hepatitis C negative. And we'll talk mainly about liver and kidney transplantation here. The kidney transplantation piece is important because, number one, there's a big prevalence of hepatitis C and end-stage renal disease in kidney transplant patients. And number two, a lot of the initial proof of principle trials done looking at hep C viremic to aviremic transplantation have occurred in kidney transplant recipients. So in the pre-direct acting antiviral era, also known as the interferon era, or as Dr. Dietrich likes to call it, the bad old days, we only really considered transplantation for hepatitis C positive donors into hep C positive recipients. And that was for two reasons. Number one, we didn't want to transplant someone with a hepatitis C positive organ if they were negative, because we didn't want to give them the infection, because we didn't really have a good treatment regimen to offer them after transplantation. Also, if a patient was a hep C positive recipient, whether they received a hep C positive organ or not, reinfection of the liver graft was universal in these patients. So all these patients were going to have recurrence of hepatitis C anyway, so it sort of makes sense to utilize these organs for these patients. And the early data that were published in sort of the mid-90s bears that out. So early data suggested that transplantation with a hepatitis C positive liver into a seropositive recipient didn't impact adversely on survival. Now, of course, these are all well-selected organs, right? So these are all livers with minimal fibrosis and otherwise good quality organs. This was confirmed in larger registry studies where they looked at the UNOS data, again, sort of in the mid-90s. And what was interesting here was that hep C positive to positive transplantation actually suggested improved survival in these patients. And the reason for that probably has nothing to do with the grafts themselves, but probably has everything to do with the fact that these patients were healthier when they received their transplant. So this is in the pre-MELD era. So back in the day, they used to order patients on the waiting list, really depending on where they were in the hospital and how sort of generally sick they were. So status 1 were patients in the ICU with less than 7 days to live. Status 2 were patients who were in the ICU. Status 3 were patients who were in the hospital. And as you can see from these data here, more of the patients who got transplanted with hep C positive livers were just less sick. They were status 3 as opposed to status 1 or 2, which tells me that these patients probably got transplanted earlier in their course, and as a result of that, had a better post-transplant survival. So better to get transplanted with a hep C positive organ than to wait on the waiting list. There were some contrasting results from a European multi-center study. This was published in 2011, which contained 700 patients, 11% of whom received livers from hep C seropositive donors. What was unique about this study was they actually looked at the viremia status of their donors. So around 43% of their donors were viremic. And although there was no statistically significant difference in post-transplant patient and graft survival, if you look at the numbers here, there is a little bit of a decline in survival when you look at patients who received organs from hep C positive donors, whether it was seropositive or RNA positive. And what the authors here hypothesized was that these patients had a more rapid recurrence of hep C in their graft. But these data weren't sort of universally borne out. And remember, this is in the pre-direct acting antiviral era. So now we have much better drugs to treat hepatitis C than interferon and ribavirin. So these are a list of the currently available direct-acting antiviral regimens. I highlighted sort of the big four, the ones that we use most commonly. So that includes elbasvir grisoprevir, also known as Zepatier, and ladipasvir sofosbuvir, which is also known as Harvoni. Those are useful for treating genotypes 1 and 4. And then we have our pan-genotypic regimens. So these can treat any genotype of hepatitis C. So that includes glecaprevir, pibrentasvir, also known as Mavorit, and sofosbuvir, velpatasvir, also known as Epclusa. And those can treat any genotype of hep C. We also have a salvage regimen for patients for whom direct-acting antiviral therapy fails. We can utilize Vosevi, which is essentially Epclusa plus this other drug, voxilaprevir. So we really have a treatment regimen for any patient with hepatitis C. When we talk about the post-transplant setting, there are a few things that we have to keep in mind. So, there are some drug-drug interactions that we have to be mindful of. So, generally speaking, we prefer the sofosbuvir-based regimens like Harvoni or Epclusa, mainly because there's not significant interactions with calcineurin inhibitors. The protease inhibitor-based therapies like Mavorit or Zepotir can interact with calcineurin inhibitors, especially cyclosporin. But if you watch their immunosuppression levels closely, this generally isn't a problem. In terms of randomized trial data for treatment of hep C in the post-transplant setting, so there are only a few trials using a couple different regimens. So the ones that we have clinical trial data for include Mavorit, Harvoni, decladisvir, which is also called Declinza, and Cimeprevir, which is Alizio. This is a busy slide, but what I want you to take away from this is that we really, again, have a treatment for every genotype of hep C, for any degree of fibrosis post-transplant, with excellent SVR, with excellent sustained virologic response. The one exception, I would say, are in patients who have decompensated cirrhosis post-transplant, but that's a decreasing population because many of these patients are being treated early. And if we can treat these patients early, we can avoid them becoming decompensated in the post-transplant setting. We also have real-world data with direct-acting antivirals that shows excellent outcomes. So these are data from the Hep C target cohort. This is a prospective cohort of patients with hepatitis C who are been followed for many years. And it included 347 post-liver transplant patients. Now these are patients who have been many months or years post-transplant. So when we talk about treating patients very early post-transplant in the setting of positive to negative transplantation, we have to take these data with a little bit of a grain of salt because these are patients who have been infected with hepatitis C, generally speaking, for a longer period of time. But they treated patients with genotypes 1 through 6. And this is a retrospective study, so the treatment regimens were just determined by the provider. But again, what you can take away from this is that no matter what the treatment regimen, these patients were cured 95 to 100% of the time. And that was true whether or not they used ribavirin. And the only things that predicted a lesser response to treatment were patients with decompensated liver disease. So patients with high bilirubins, low platelets, or low albumin. We also have data from our own population, which we collaborated with Georgetown, where we looked at outcomes with direct-acting antiviral treatment in a population of patients with simultaneous liver and kidney transplantation. So we had 34 of these patients. Genotypes 1 through 3 were represented here. And 70% of these patients were treated with Harvoni, with or without ribavirin, and 97% achieved an SVR. We also looked at changes in their immunosuppression regimens and their renal function. Remember, these were simultaneous liver and kidney transplant recipients, and we didn't detect any appreciable changes in any of these levels. So all of these data have really led to an uptick in utilization of hep C positive livers for hep C positive donors. So even though we were doing this beforehand, before the advent of direct-acting antivirals, utilization of hep C positive livers was still pretty low. But after the institution of the early direct-acting antivirals like telaprevir and boceprevir, and now really in the interferon era, the uptake of these organs has really increased. Along with that, we've seen a decrease in the discard of hepatitis C positive livers. So liver discard is when someone goes and procures the liver but then doesn't use it. So, which is really a tragedy because then we can't, actually use that liver to save someone's life. So we've actually cut down on the number of discards in the modern era. Okay, what about the story with kidney transplant? I mentioned that we have a high prevalence of hepatitis C in the end-stage renal disease population, so 7 to 14%. So can we do the same kind of thing where we utilize hep C positive kidneys for hep C positive recipients? Well, the data here were a little bit more mixed. Early studies suggested worse outcomes for hep C positive kidney recipients, and that was related to liver-related mortality, recurrent glomerular disease, and new onset diabetes. But other data suggested that patients had good outcomes with this. One observational cohort from Spain suggested that patient and graft survival was similar in patients who received hep C positive versus negative kidneys. There's a little more recent data on this as well that looked both at the interferon era as well as the direct-acting antiviral era. And similar to what we saw before, there is a slightly significantly decreased survival in patients who receive Hep C positive kidneys. But if you look at the actual numbers, Hep C donor negative to recipient positive, the 1-year survival is 95.3%, and a Hep C donor positive to recipient positive is 94.5%. So they're both 95%, but statistically it's significant because these are big numbers. But overall, if I'm counseling a patient on this, these survival numbers look pretty similar. And that's what we have to sort of talk about when we talk to patients about the prospect of getting transplanted with a hepatitis C positive organ. Because the choice isn't so much, you have two organs in front of you, Hep C positive and Hep C negative, because of course if you have that choice, you're going to go with the Hep C negative. The choice really here is, do we take any organ, Hep C positive or negative, or do we stay on the waiting list and wait for a Hep C negative organ that may come years down the line or that may never come? And so when we look at this in terms of overall survival, we see a clear benefit to accepting any organ, Hep C positive or negative, compared to waiting on the waiting list. So these are data, again, this is from the pre-direct-acting antiviral era, but even here, patients who got transplanted did much better than patients who remained on the waiting list waiting for a Hep C negative organ. So if I'm counseling a patient and we have the choice here, I would advise them to take the first organ that they can get, and especially now that we have excellent treatment regimens to treat patients post-kidney transplant. So the regimens that we have randomized trial data for in the post-kidney transplant setting are Mavorite and Harvoni, and these patients do very well post-transplant as well. This again has led to an uptick in the utilization of these organs from the interferon era to the direct-acting antiviral era. So I would argue with these data that we really now can consider transplantation of organs from hepatitis C positive donors, both antibody positive and NAT positive, into uninfected recipients. And this is because we have direct-acting antiviral therapy that's led to high cure rates for all genotypes of hepatitis C. And we have regimens that can treat hepatitis C in really transplant recipients of any organ. And so this has really led to the American Society for Transplantation issuing a consensus statement that states that the mismatch between organ supply and demand results in an ethical mandate to improve organ utilization, which includes the broader utilization of hepatitis C positive organs. So what data do we have to support that practice? So in addition to the case report I mentioned earlier, there was a case series actually of unintentional transmission of hepatitis C. So this was a case where there was a high-risk donor who at the time of their donor testing was negative for Hep C RNA, who actually wound up transmitting hepatitis C to 3 different recipients, 2 recipients of this patient's kidneys, and then the recipient of his liver. And this is because he was probably in that eclipse period before the hepatitis C RNA became positive. So in all of these patients, they became positive for Hep C RNA. They were infected with hepatitis C, and they received direct-acting antiviral treatment and had successful SVR with no graft compromise. So this, again, is proof of principle that this practice can work. So what systematic data do we have for this? So the first trial that came out looking at this was the Thinker trial, and this was published in the New England Journal of Medicine in 2017. And this was an open-label pilot trial done by the group at University of Pennsylvania, where they looked at transplantation of kidneys from hepatitis C viremic donors into uninfected recipients. They restricted their donors to genotype 1 because the drug that they had from the sponsor was Zepitir, which treats genotype 1 and 4. So they transplanted patients, and then once they became RNA positive, they treated them with elbasvir-grazoprevir, also known as Zepitir. They included patients with long anticipated kidney transplant waiting times and excluded patients who had known liver disease, those who were at high risk for liver disease, and also those patients with FSGS because of a risk of recurrent disease in the transplanted kidney. So part of their protocol, they checked Hep C RNA on day 3, and they started treatment as soon as they became positive. They treated patients for 12 weeks, and they ultimately wound up enrolling 10 patients into their protocol. So from the time that they listed patients to accept a Hep C viremic organ, the median waiting time on the list was 58 days. Just for context, At 30 days, only 2.2% of kidney transplant patients nationally get an organ offer. So this is a really short period of time to wait for a transplant. All of these patients developed viremia by day 3 post-transplant. They started treatment, and all of these patients had sustained virologic response after completing therapy with no adverse events at 6 months out. So they continued their follow-up in a subsequent study that looked at the 12-month outcomes of these original 10 patients, and then they added another 10 patients where they had 6-month follow-up data. They, in addition to the other outcome measures that they looked at previously, they also looked at quality of life scores because they wanted to examine whether there was a stigma associated with acceptance of a hepatitis C positive graft, and they looked at post-kidney transplant renal function. So in terms of their hep C cure, all these patients again were cured. And remember, these are all patients who got genotype 1 kidneys and got treated immediately after, within a couple of days of transplant with Zepatier. But all these patients, their hep C RNA tanked and was undetectable by week 4 and remained undetectable thereafter. In terms of their quality of life scores, so they actually had maintained their the same mental quality of life from before transplant, and actually had improvements in their physical quality of life post-transplant, with a slight dip in the immediate post-transplant period, probably just related to having to recover from a transplant. In terms of their renal outcomes, so as one would hope, after transplant, serum creatinine improved in all kidney transplant recipients. And actually what was interesting was that in the thinker recipients, they had better outcomes at 12 months in terms of their renal function than a matched cohort of kidney transplant recipients who received kidneys with similar donor risk scores. And they hypothesized that the reason for this is that hepatitis C positivity is included in the donor risk score. So if that would elevate the donor risk score, but you treat the hep C afterwards, those kidneys will function more like lower risk score kidneys. So these patients did very well in terms of their renal function post-transplant. In terms of adverse events, remember now this is a little bit longer follow-up than the initial study. So 5 of these patients developed transient LFT elevations. 1 patient developed proteinuria, but this patient had IgA nephropathy pre-transplant, so it was thought maybe related to their pre-existing disease. 5 patients had delayed graft function and needed dialysis within 1 week of kidney transplant, but there were no serious adverse events related either to the hep C or due to treatment with Zepatier, and there was no allograft rejection in this population. So in summary for the thinker trial, which again is sort of the first pilot study looking at whether we can transplant hep C viremic organs into hep C negative recipients, this seemed to be safe and effective. Hep C cure was achieved with prompt initiation of therapy, and with prompt initiation of therapy, there was no appreciable detriment to either kidney or liver function, with no increase in allograft rejection and no impact adversely on quality of life. A similar study, but with a little bit of a unique spin on it, was also done at Hopkins. So here, they looked at the use of perioperative direct-acting antiviral therapy. And this, I think, is really interesting. So similar to the thinker trial, they used elbasvir-grazoprevir, but they didn't limit their donors to genotype 1. So they included genotypes 2 or 3. And if they happened to get a kidney from a genotype 2 or 3 patient, they just added on sofosbuvir to the Zepatier regimen. So they transplanted 10 of these patients. Again, the waiting time was really short, only 1 month. And what was really cool about this is 5 of the patients never developed any detectable hep C viremia. And of the patients who did, they kind of blipped up a little bit and then were all viral load negative by week 2. So these patients got a dose of Zepatier on call to the OR. So they started pre-transplant and then just continued throughout. So the question here is, was this effective like pre-exposure prophylaxis and these patients didn't actually develop a set-in infection, or did they just suppress the virus long enough for them to cure it like we would normally with chronic hep C? And I think what this sort of drums up is whether we can shorten the duration of treatment in this kind of setting. Do these patients really need a full 12 weeks of treatment like we would give for someone with chronic hepatitis C, or can we limit it to 4, 6 weeks or whatever? They actually looked at whether or not there was an immune response in this trial also by looking at T-cell signatures, but the data were a little bit inconclusive. So it's hard to know whether or not some of these patients actually developed an immune reaction to the hep C infection. All right, so what about the experience in liver transplant? So our data here are actually a little bit more limited. The biggest study so far that's come out in the published literature is from the Stanford group, where they transplanted 10 patients from March 2017 to January of 2018. These were recipients who were at a high estimated risk of waitlist dropout, so patients who were sicker than their MELD, or patients with HCC that was at high risk of exceeding Milan criteria, so they were at high risk of dropping out of the liver transplant waiting list because of this. And they offered viremic donor organs to these patients. What was different about this study compared to the other two trials I just mentioned was that this wasn't a pharmaceutical-sponsored trial, so they didn't have drug at hand. So what they had to do was transplant patients, wait for them to become positive, and then request medication from the insurance company, just like we would with any patient who we treat for hepatitis C. And that's actually the usual process that we do it here. So they looked at, so this is a little bit more of a real-world outcome study. So they looked at outcomes including hep C treatment regimen and duration, exposure to immunosuppressive agents, the hep C viral kinetics, changes in their liver chemistries, and then potential complications. So they transplanted 10 recipients like this. The median age of the recipients was 61. 40% of them were women. 7 out of 10 had a prior hep C infection, so they had previously been treated for hep C, but they were all aviremic at the time of transplant. And they had a median lab MELD of 16, so actually most of these patients were listed with hepatocellular carcinoma exception points. So these patients were a little less sort of biochemically sick than some of the patients that we see. The donors had a median age of 33. So again, as I mentioned earlier, our hep C positive donors are getting younger. So these were very young donors. They all were increased risk donors, meaning they had a risk of transmitting infection to the recipients, which is obvious because they're all hep C positive. And all of these folks were hep C NAT positive. In terms of treatment, so all the recipients developed detectable hep C viremia by day 4 post-transplant. And they got a bunch of different genotypes here, so a mixture of 1 and 3. And all of these patients were treated with sofosbuvir-based therapy. So the prior control trials that we looked at all had protease inhibitor-based therapy with elbasvir-grazoprevir. Here, these patients were treated mainly with sofosbuvir-based therapy. And the median time to treatment was 42.5 days. So in terms of their outcomes, so all of these patients also achieved an SVR. So these patients were all cured of their hep C. But there were a couple complications. So one patient developed anemia and leukopenia, which was thought to be related to them having ribavirin included in their hep C treatment regimen. They were also on Bactrim for PCP prophylaxis post-transplant, so that probably contributed to that. And then 3 patients developed rejection. So one patient had both T-cell and antibody-mediated rejection, and then 2 patients each developed T-cell and antibody-mediated rejection. So this is a little concerning because it's a little bit higher of an incidence than we would normally see in the post-transplant setting. And the authors had a couple hypotheses for why this might be. So even though they used sofosbuvir-based therapy, which in general has a lower risk of drug-drug interactions, maybe there was some subtle drug-drug interactions that altered immunosuppression levels. Although in the patients who developed rejection, they actually mapped out whether these patients had subtherapeutic levels of tacrolimus or cyclosporin, and they really didn't. So unless they were missing subtherapeutic levels in between lab checks, it seems less likely. There's also a concern for direct-acting antiviral-induced immune-mediated graft dysfunction. So this is graft dysfunction that can occur after hepatitis C cure, and this was seen a lot more commonly in the interferon era, because remember, interferon is an immune stimulant, so there were patients who developed a plasma cell-like hepatitis, so almost like an autoimmune type hepatitis in the post-transplant setting when treated with interferon. So that rate was about 7% in the interferon era. In the direct-acting antiviral era, that's much less common. It only occurs in around 3 to 4% of patients, so that could be an explanation for this, but it's a little unclear. And then one patient who developed antibody-mediated rejection was actually noted to be highly sensitized before transplant with a lot of circulating preformed antibodies. So it's possible that this patient was already predisposed to developing this kind of rejection. But it's a little bit hard to interpret these data because this is a small group of patients, but it does show us that close monitoring of these folks is needed. But they conclude that transplant with hep C viremic livers into aviremic recipients results in acceptable short-term outcomes. I should also mention that all the patients who developed rejection were treated for rejection and still have intact graft function post-transplant, even though this is a relatively short period of follow-up. So, we've adopted a similar protocol here, actually, for the transplantation of hep C, of organs from hep C viremic donors into uninfected recipients. And we do this for patients who are at a high risk of waitlist dropout or death. And when this occurs, we consent patients, usually in the office, for this process. We go through a multi-step consent process that involves the hepatologist, the surgeons, the transplant coordinators, and we inform the patients of the risks and benefits. Again, we're sort of weighing the risk of keeping someone on the waiting list and waiting for a hepatitis C negative organ where they could have complications and die on the waiting list, or accepting any organ and potentially dealing with the complications of hepatitis C post-transplant. Patients are also consented at the time of their organ offer, which is just standard practice, where the patient is informed of the donor qualities, including whether the donor is seropositive only or seropositive and NAT positive. So after patients get transplanted with a seropositive or a NAT positive liver, we check the viral load very frequently post-transplant. So we check it at day 3 and then weekly for a month and then every other week for 3 months. Most of these patients get viremic very soon after transplant, about day 3. And then once we detect hep C RNA, we order treatment. Again, this isn't sort of a sponsored trial, so we order treatment from the insurance company just like we would for a patient with chronic hepatitis C. Our protocol calls for use of sofosbuvir-based therapies, preferentially, mainly so that we can limit potential drug-drug interactions with calcineurin inhibitors. Although we can use protease inhibitor-based therapies, and it's really dependent up to the provider. So this is what we've done so far. We have 13 patients who we've transplanted who were hep C negative, who received organs from hep C viremic donors. Our median age at transplant was 58. The median allocation MELD at transplant was 30. And our patients, I think, were a little bit sicker than the group at Stanford, actually. We also transplanted 5 of these patients, received a simultaneous liver and kidney transplant. We had mainly genotype 1 donors, and there was a good mix of, in terms of treatment regimen, about half of the patients got treated with Mavorite, which is a protease inhibitor-based therapy, and half got treated with a sofosbuvir-based therapy, which is Harvoni or Epclusa. In terms of time to treatment start, it was very similar to the Stanford group. We started treatment at a median of 42 days. And so far, all of our patients, except one, has had an end of treatment response, and one patient's had a sustained virologic response. The rest of the patients just haven't had a chance to get there yet. In the one patient who hasn't started treatment, this is because of insurance hurdles which have been overcome, and the patient is about to start on treatment very soon. In terms of how these patients have responded to treatment, so these are the hep C viral loads. This is weeks post-transplant. So all these patients started treatment at varying times post-transplant, but once they did, they all had a significant decrease in their viral loads and all have had significant response to treatment. So these patients have done very well, and so far with no evidence of any graft dysfunction or rejection. So, promising data, but we obviously don't want to go into this with blinders on. We have to recognize that there are risks associated with this process of transplanting patients with hep C viremic organs and giving them a new hep C infection post-transplant. So some of the concerns that we have to look at are the development of fibrosing cholestatic hepatitis. There are a lot of financial considerations that we have to keep in mind. There's risks of new onset diabetes, there's risks of new onset glomerulonephritis, and we have to consider whether those signals that we saw in the Stanford data with immune-mediated graft dysfunction are real or whether that's something that was just unique to that population. So fibrosing cholestatic hepatitis is something that we really worry about in the post-transplant population. This is a severe form of hepatitis C that can develop in up to 10% of transplant recipients. It's very aggressive. It's characterized by high titers of hep C RNA, jaundice, and severe cholestatic liver dysfunction. And if these patients develop this, they can progress rapidly to liver graft failure, graft loss, and even death. But luckily, we have effective treatments for this. So the direct-acting antivirals are useful in the setting of fibrosing cholestatic hepatitis. So there were data from the SOLAR 1 and 2 trials, which were clinical trials, which looked at the use of ledipasvir sofosbuvir. So in patients they included around 4 patients who had fibrosing cholestatic hepatitis. And all of those patients wound up having successful cure with the use of ledipasvir sofosbuvir. Sorry about that. Okay. One of the big concerns with this, though, is the financial risks associated with having to treat hepatitis C in the post-transplant setting. So as we are all probably familiar with, the cost of hep C regimens can be high, ranging from $26,000 for Mavorite up to $96,000 for a 12-week course of Harvoni. And despite recommendations from our societies like the American Association for the Study of Liver Disease and the Infectious Disease Society of America that state that all patients essentially with hepatitis C infection should be treated, there's still a lot of denials for hepatitis C treatment. One study that looked at this, they looked at data from a specialty pharmacy looking at treatments for hepatitis C that were requested, and 44% of these requests, even as recently as the first quarter of 2017, were denied. So this is something that we have to really consider when we think about this. We have to think about where the patient lives also, because in certain states, Medicaid has more stringent requirements on treatment for hepatitis C, requiring certain levels of fibrosis in the patient. So this is something that we have to consider, and programs have to think about this if they're thinking about transplanting patients with viremic organs. Luckily for us, when payers see that the patient's post-transplant, in general, they don't really balk at paying for treatment, but this is something that we have to think about. One of the ways that we can try to convince payers to cover this would be with cost-effectiveness data. So we actually have some modeling data that suggests that this strategy of transplanting patients with hep C viremic organs is actually cost-effective. So this is a modeling study that was published last year that looked at both survival benefit in terms of gain in life years as well as cost effectiveness. And they compared essentially patients who were modeled to remain on the transplant waiting list, waiting for a hep C negative liver, and patients who were willing to accept any donor liver. So what they found in their modeling data anyway was that there was a survival benefit for accepting a viremic donor once the patient's MELD was 20 or higher. And this was seen irrespective of where the patient lived, so irrespective of the UNOS region. And although the highest benefit was seen in region 1, which is a high prevalence of hepatitis C in the donor population, as well as a long waiting time on the transplant waiting list. In terms of cost effectiveness, transplantation of hep C viremic livers into uninfected recipients seemed cost effective once the patient hit a MELD of 22 or higher, with a maximum cost effectiveness when the patient hit a MELD of 28 or higher. So this does seem to be a cost effective way of treating patients rather than having them stay on the waiting list and having to deal with all the complications of end-stage liver disease that can develop when a patient doesn't get a transplant in a timely manner. So all of these data have already led to an increase in utilization of hep C positive to negative transplantation. So these are UNOS data that look at the number of positive donor to negative recipient matches. So you can see from 2015 to 2016, there was a huge explosion in the use of these kinds of organs, essentially a doubling in thoracic, liver, and kidney transplant. For liver transplant alone, so far, based on the UNOS data, nationwide, there have already been 30 hep C viremic to uninfected transplants done. So that includes ours, Stanford's, and some other centers. And of the ones that were done in 2017, we already have 1-year outcome data that suggests these patients have a comparable survival to patients who receive aviremic organs at 92% at 1 year. So these patients generally do very well. So I'll conclude by saying that the opioid epidemic has led to an increase in donors, many of whom are infected with hepatitis C. The utilization of these organs can turn what's really a tragedy in the opioid epidemic into a blessing for many of our sick patients who are disadvantaged by the current system. With prompt antiviral therapy, we can transplant organs from hep C viremic patients into uninfected recipients, but we really need longer-term outcome data to see whether or not these folks are going to do well in the long term. But the ultimate problem here is the mismatch between organ supply and demand. So we need to reduce the demand by coming up with better treatments for chronic liver disease, and we need to increase the supply not only by strategies like transplantation of hep C viremic to uninfected donors, but also just by encouraging organ donation. So with that, I'll end. Thanks.
James, that was great. It's amazing to see a disease which was, life-threatening and chronic turn to something that is now curable. My question is again about the payer model. So you've made a clear case that it's cost-effective long-term. It's obviously the right thing to do for patients who are HCV positive. Do you want to talk a little bit about the disincentive for payers to pay and how we can sort of get over that as a society?
Yeah.
A societal question, how we can get all these patients treated early in their course rather than later.
Early in the direct-acting antiviral era, payers wouldn't pay until patients had advanced fibrosis or cirrhosis, so F3 or F4. And, that has clearly been shown to be the wrong strategy. I mean, we need to treat more patients early, and we need to treat them sooner, not only in the transplant population, but just in the general population. Part of the problem with the increase in incidence of hepatitis C, especially in the injection drug user population, is that a lot of these states have restrictions on sobriety. So patients can't get, if they're on Medicaid, they can't get their hep C treatments approved if they're injection drug users. Now, the scientific community has gone away from restricting that, but a lot of payers are still restricting therapy based on that. So I think we can reduce the incidence of hep C if we just offer more treatment to patients. And if we look at the bigger picture long term, it is cost effective because it's way more expensive to take care of a dying cirrhotic in the ICU than it is to treat their hepatitis C, especially with the newer regimens. Thankfully, the cost has been going down with, increased competition and more regimens that are out there. So, Mavorette, which in some cases can be an 8-week regimen, is only around $22,000. So I think there is an incentive there for payers to cover the cost, but we're still lagging behind. There is data that suggests that, there was a study that looked at hep C treatment rates in 4 different states, and treatment rates of those patients was still only around 20%. And there's a lot of disparities in terms of race and gender even, and so there's a lot that needs to be done with getting more patients access to treatment.
Thanks very much. So as we know with HIV, viral load undetectable doesn't mean viral load free, and there's reservoirs. Is hep C the same? And if there is, are there long-term sequelae that we'll see down the road in transplant patients? And are we consenting patients and having them understand that when we don't really know ourselves?
Right. So yeah, that's a good question. There are some data to suggest that there are hep C reservoirs even after patients achieve an SVR in hepatocytes. When they've looked at this, the RNA that's present isn't really capable of replication, but there is some concern about occult hep C infection, which I think is maybe what drives some of the data where we see hep C seropositive only donors transmitting hep C to recipients. So I think it's possible, and I think it's something that we have to monitor, but we really don't know what the effect of that is.
I assume that at least some of the livers that are transplanted actually have some degree of fibrosis. Mm-hmm. What happens to that fibrosis after it's transplanted and they receive the hep C treatment?
Right. So we really don't transplant the livers if they have any appreciable fibrosis, maybe mild fibrosis like F1 disease. If we transplant a patient like that, the short answer is I don't know, because we don't do serial protocol biopsies on a routine basis unless it's clinically indicated. So it's hard to know whether that fibrosis regresses with treatment, whether it stays the same. We just don't have that data because we don't do serial biopsies as protocol. So if I had to guess, I would say it probably doesn't change afterwards, although there could be some regression.
I want to point you to an interesting article yesterday in the Wall Street Journal, which is actually an article about a transplant surgeon, it's not HIPAA, from Bob Montgomery from NYU, who just received a hep C positive heart transplant. It's an interesting article, and a sign that the transplant community are really going gung-ho in this area. So well done, fantastic talk.
Thanks.